Harvard Divinity School.
Into the Crucible, Psilocybin and Spiritual Care at the End of Life, February 28th, 2024.
Welcome, everyone, to our first Psychedelics in the Future of Religion event for the spring semester. My name is Jeffrey Breaux, and I'm a graduate student at Harvard Divinity School and a researcher with the Center for the Study of World Religions, where, along with Paul Gillis-Smith, I convene the Psychedelics Sacred and Subversive Reading Group. Tonight's event is part of the popular series on psychedelics in the future of religion, which is now in its fourth year. The Psychedelics in the Future of Religion series is part of the center's larger, ongoing, and evolving initiative called Transcendence and Transformation, or TNT for short. If you're interested in TNT, we'll put a link to the TNT page in the chat function. As always, the best way to stay abreast of what we're doing here at the center and its programming is to sign up for our weekly newsletter, which you can do at the center's landing page. Additionally, we hope that many of you were able to attend the center's Psychedelic Intersections conference held at Harvard Divinity School on February 17th. If you weren't able to attend, or if you're interested in rewatching any of the day's panels, recordings from the entire event will be shared through the newsletter and on the center site in the coming weeks. To give a sense for how today's conversation is going to unfold, in a minute, I will turn the floor over to Paul, who will introduce himself and today's four panelists who are joining us from Dana-Farber and Care Dimensions Hospice House. We will then both disappear and turn the floor over to our speakers, who will present together for about an hour. They will be sharing groundbreaking work on psychedelic-assisted therapies for patients at the end of life. Their talk today will introduce this new field, share results from a recent study, and discuss the role that chaplains and spiritual care providers have played in their research. As someone with feet in both psychedelic studies and chaplaincy, end-of-life care has long felt to me like the ideal place for psychedelics. So I'm particularly excited to see the progress this interdisciplinary team has made towards making these therapies safe and accessible. With all of that logistical information out of the way, I will turn the floor over to Paul Gillis-Smith.
Hello, everyone. I'm Paul Gillis-Smith, research assistant at the CSWR and grad student at Harvard Divinity. Today, we have a power panel featuring a number of researchers from a psilocybin-assisted therapy study on demoralization in hospice patients with Yvan Beaussant, Alden Rinaldi, Roxeanne Sholevar, and Daniel Twomey. Yvan is a hematologist and palliative care physician investigator trained in psychedelic-assisted therapies and an instructor in medicine at Harvard Medical School and instructor in psychosocial oncology and palliative care at the Dana-Farber Cancer Institute. Dr. Beaussant's research focuses on investigating the safety and efficacy of psychedelic-assisted therapy and defining standards of care across indications and populations of patients with serious illness. Alden Rinaldi is a neurologist and hospice physician at Care Dimensions with an active clinical and teaching practice centered at the Care Dimensions Hospice House in Lincoln, Massachusetts. Dr. Rinaldi also has an academic appointment as lecturer in clinical medicine at Harvard Medical School and serves as site director for the Beth Israel Deaconess VA Hospice and Palliative Care Medicine Fellowship. Dr. Rinaldi is a therapist and co-investigator in a phase 2 pilot study of psilocybin-assisted therapy for demoralization at end of life for patients enrolled in hospice. And Roxeanne Sholevar is a psychiatrist and with a subspecialty certification in consultation liaison psychiatry, providing psychiatric care to patients with medical illness. Her clinical and research interests include care of patients with cancer and serious illness, psychoanalytic psychotherapy, and psychedelic-assisted therapies. She's also interested in medical education. And Dan Twomey is a hospice chaplain at Care Dimensions, the largest not-for-profit community hospice in Massachusetts, with over 10 years experience ministering to the dying and their loved ones. Though Roman Catholic by faith, he incorporates many traditions to serve the needs of a culturally and religiously diverse population that's cared for at Care Dimensions Hospice House in Lincoln, Massachusetts. So without further ado, I will welcome our four panelists to the stage, and Jeff and I will get out of here. The floor is yours.
Wonderful. Thank you both, Jeffrey and Paul, for inviting us. It's Wonderful. It's a real pleasure to be here and present tonight. I'm thrilled to be here with Aldo, Roxy, and Dan, who are all together at Aldo's place. I was not able to join them because I'm solo parenting tonight. But, we really come here as a team in the spirit of sharing with you all a work in progress, like a learning experience as we just finished to enroll patients in a psilocybin-assisted therapy trial for, as Paul said, for patients with demoralization and a terminal illness. So the way we have structured this talk, we very much want to present two clinical cases that we encountered in the clinical trial. And so I'm going to start by giving a little bit of background on the origins and evidence base for psychedelic-assisted therapy in the care of those with serious illness. Next bullet point, please. Then I'll tell a little bit about the design, how we designed and implemented this study in a very vulnerable population of patients with terminal illness, and how we adapted the psilocybin-assisted therapy treatment modality in this patient population. And including some considerations about how we thought about ensuring psychospiritual safety and adequate safeguards for these patients. And then my three colleagues, so Roxy will start by presenting a first clinical case of a young woman that we treated in the study that illustrates the typical mystical experience that has been described in people at the end of life having an experience with psilocybin. And then Aldo will present another patient that both of them treated with, whose experience had also a very spiritual dimension, but was very challenging. And we were fortunate enough to receive Dan's assistance in the care of this patient, and the other chaplain also who was involved in the care of this patient. And so then we'll have a dialogue with Dan, who had a key role in treating this patient. And then we'll open it to discussion and sharing about our reflection, some of our reflections, and opening up to discussion with our questions. And so we wanted to start with a quote from somebody who many of you may be familiar with, Walter Pahnke, who was a psychiatrist in the 1960s at Harvard here, and also who was affiliated to the Harvard Divinity School. So he had both those affiliations, and he was involved in the March Chapel experimentation, and also his work was focusing a lot on psychedelic-assisted therapy and serious illness care in patients with serious illness. And in his lecture, Ingersoll lecture that he gave at Harvard in 1969, he was having these words. This profound, and he was talking about mystical experience that some of the patients may have with LSD at this time in this research. And about this experience, he was saying this profound and awe-inspiring insight sometimes is experienced as if a veil had been lifted and can transform attitudes and behavior. Once a person had this vision, life and death can be looked at from a new perspective. Patients seem able to meet the unknown with a new sense of self-confidence and security. And just how inspiring, I think that really says something about what inspires us to investigate this research. In those patients, we'll tell a little bit more about the clinical need that exists in patients with serious illness, and how many of the interventions that we have currently available don't really address the distress that we see in clinical encounters. And so in terms of the background of our study, so really acknowledging the amazing work that has been done before psychedelic-assisted therapies or before psychedelics were prohibited and put on as a Schedule I substances in the 1950s and 60s, as psychedelic research was really exploding. A lot of it was focusing on patients with cancer and patients at the end of life. So there were clinical studies extensively conducted in this context in the mid-20th century. Stan Grof, who is a pioneer in this field, who most of you know, was also really interested in this domain of the psychedelic research and wrote this beautiful book with John Halifax, The Human Encounter with Death, where they tell about their experiences in conducting psychedelic research in terminally ill patients. And they were saying it's hard to imagine a more useful way to combine medicine, psychology, and religion than psychedelic therapy. And so that's very much how we approach things as well. And you'll see how we try to implement that in how we integrate those different disciplines in our work. Next slides. And so fast forward, we're psychedelics are still, like on the Schedule I substance that is prohibited and cannot be used outside of a clinical setting, clinical research. And yet, since the early 2000s, as the psychedelic renaissance is moving forward, a significant amount of this work has involved patients with serious illness, and especially cancer. And research has shifted from LSD or DPT to psilocybin mostly. So there's been this is a list of the clinical trials that have reported findings in these patient populations using psychedelic-assisted therapy. Most of them involve psilocybin, and some of them one of them involved LSD, a Swiss trial, and another one MDMA. And among those trials, some that have had the most impact were the Johns Hopkins trial and the NYU trial, conducted and published in 2016, that were implementing rigorous methods of comparing people with crossover methods and showing remarkable results in this cohort using one dose of psilocybin, 25 milligrams, in patients who had cancer and significant distress, either anxiety or depression. And these trials, so this one and the NYU trial showed similarly that psilocybin had a rapid, substantial effect on psychoexistential distress and improved quality of life and spiritual well-being in these patients. And we were seeing results that are really not usually seen in this patient population for distress, with 80% of significant reduction in anxiety and depression at 6 months. And those effects were maintained over time, and 70% of patients were in remission at 6 months as well. And very interestingly, we're shifting away from a classic drug model where therapeutic benefit are obtained via a pharmacological agent. Here there is the pharmacological agent, but also the therapeutic effect is thought to be mediated by the subjective experience that psychedelics induced. The change of consciousness and the kind of experience that people may have with these molecules. And those kind of experiences include experiences qualified as mystical, and we'll say more about this, but also a whole range of emotional processing, grief processing, trauma processing, and interpersonal dynamic work that can happen through all the drug and non-drug sessions of the therapeutic model. So a little bit more about mystical experience. So this is not a concept that has been traditionally evoked in the medical language, but psychedelics-assisted therapy, because of the effects of psilocybin and psychedelics, have really reintroduced this notion in the medical literature and model. Pankey again, Walter Pankey and Bill Richards have and others have done some work to try to qualify what the psilocybin or psychedelic-induced mystical experience look like, and define several characteristics that are listed here: a sense of unity and interconnection, a sense of sacredness, a deeply felt peace and joy, transcendence of ordinary time and space, ineffability, meaning the difficulty, the challenge to use language to describe the experience. And the noetic dimension is like the feeling that the experience is real and really has a strong sense of reality. But apart from what our Western model has, how we have qualified these experiences, other cultures that have been holding traditions and knowledge on these on psychedelics and plant medicines also really relate to this sense of a mystical experience. Here we have a beautiful quote from Maria Sabina, who was a curandera from Maztec culture, and she said, "The more you go into the world of Teonatl, the more things are seen. You also see your past and your future, which are there together as a single thing, already achieved, already happened. I saw stolen horses and buried cities, the existence of which was unknown and going to be brought to light. Millions of things I saw and knew. I knew God, an immense clock that ticks, the hands going slowly around inside, the stars, the earth, the universe, the day and the night, the cry and the smile, the happiness and the pain. He who makes it to the end can even see that infinite clockwork." And in a research that we conducted in cancer patients with depression, one after her psilocybin experience was saying, "Now I know of what it feels like to be at peace, at calm. All is well with the world. All is well with you. No matter what happens, it's okay. You're in the moment." So as much as we had, the set and setting, and as the treatment modalities we're trying to preparing for this kind of experience to happen, and because we know that they may be associated with positive outcomes, it's important to know that not all patients have this kind of experiences, and I think one of our clinical case will illustrate that very much, and people may have really challenging experiences also that really shake them to the core. So there is an importance to take this into consideration, like this in this qualitative research, where like the previous quote that I mentioned from the cancer patients came from a qualitative research that I conducted with patients who had a psilocybin experience in a clinical trial. And really some of the main themes around how people view acceptability of their psilocybin experience were around the idea that these experiences are really intense and very demanding, especially in the context of cancer. And yet, in the proper conditions where people feel safe about going with this intensity and the demandingness, they view this as integral to their healing process. But there is this tension between resisting to an experience that is unknown, intense, demanding, and the awareness that it's helpful to surrender to it. And for this, people need to feel very trusting and very safe to allow themselves to surrender into the experience. And they put themselves in a very vulnerable state where they are suggestible to the setting, the therapies, the people around, and they're dependent on people around as well during that vulnerable state. So these are really very important phenomenon or effects of the treatment that are being taken into consideration in this treatment model. And hence all the work around set and setting that has been developed, and really the idea that it's not only a pharmacological intervention, but also in the context of a container, a therapeutic container. Next slide, please. So to introduce a little bit more about the study that we've been conducting, it's a small pilot study of psilocybin-assisted therapy to address demoralization in patients who receive hospice care at home. Next slide. It's even for a small study, it's a huge effort. We received so much support from Dana-Farber Care Dimensions, Beaussant Institute, who provided the drug, the Hefter Research Institute, and many philanthropic funders who made this work possible. It's taken a lot of people to make this happen that we don't have time to acknowledge here, but really we are, the four of us are in debt to all these people to have made this work possible. Next slide. And so the reason why we wanted to conduct this study with hospice patients is first because there is a huge clinical need, and also because hospice care is propose a whole person approach, including really attention to of course the physical aspects of death and dying, but also the psychosocial aspects and spiritual aspects, and really provide interdisciplinary care to. There is a lot of attention on therapeutic alliance and providing a safe container for patients and families. There's a close follow-up. So that really appeared an ideal setting to evaluate how we could, to evaluate how we could adapt psilocybin-assisted therapy in patients with terminal illness. It's also a lot of people who are taken care by hospice each year. And many of these people experience deep psychological and existential distress, not only patients, but also families. And much is done to provide relief and comfort to these patients. And yet there is really room to improve our outcomes here. Next slide. So our primary objective was to assess the feasibility of psilocybin-assisted therapy in these patients. So can we treat patients? Can we first recruit them, treat them, evaluate them? These are very fragile patients. To qualify for hospice, people need to have an expected prognosis of less than 6 months. But in most of the case, they have, people live 2 weeks to a month in hospice after admission. So a very fragile population. And secondary objectives were around safety and efficacy, of course, with our primary efficacy outcome being demoralization. Next slide. So we were enrolling patients who received home hospice care at Care Dimensions, who were adults 21 years old or older. They could have any terminal illness, cancer and non-cancer. Their palliative performance scale or score had to be 40% or greater, meaning people have to have some degree of independence despite their illness and not basically being bedbound and requiring a lot of assistance. And the main reason for that is because we had to transport people from their home to the hospice house to deliver the dosing of psilocybin. And they also needed to have a moderate to severe score or demoralization on the demoralization scale that we used, because this research was centered on existential distress. And I'll say a little bit more about demoralization in a subsequent slide. And maybe one thing that sets apart this trial from previous clinical trials in populations of cancer patients was really we were deliberately targeting a real-world sample of patients with serious terminal illness. So willing to enroll patients with comorbidities, with a lot of treatments, who are classically excluded from clinical trials, including in the context of cancer. Next slide. So this was a mixed method pilot trial, meaning that we used both quantitative measures and qualitative measures. So we interviewed, after their participation, we were trying to interview patients, family caregivers, and also hospice staff members. We enrolled 15 patients, and we were able to treat 10 of them. 5 patients had their illness progressing before we were able to treat them. People received 1 dose of psilocybin 25 milligram. So if you look at the diagram below, we were initially screening patients, and once they were eligible and enrolled, they would start their preparation phase with 2 preparatory sessions, which were happening at their home. And then once ready, they would come for the dosing day at the hospice house, just for the day. They had the possibility to stay overnight if needed, but the default modality was to discharge them home at the end of the dosing day. And then the therapist would come back to their home the next day and a week after for 2 sessions of integration. And then they would have their qualitative interviews, and then we follow them up to 6 months monthly. So the therapy was administered by therapist dyads, and you have a photo of our wonderful therapy teams. We tried to have a chaplain who moved out of state after his training, and we were not able, unfortunately, to recruit another chaplain as a therapist, even though we've worked, as you will hear, a lot with chaplains before and after the therapy. We haven't been able to have a chaplain actually sitting with us as a therapist. But other team members were, you'll hear from Aldo and Roxy, one a neurologist and a psychiatrist. We had a music therapist, social worker, right. So so this interdisciplinary team was reflected within the therapy dyads, but also beyond the therapy dyads. We collaborated with the hospice interdisciplinary team at every step of patient's treatment. So that really informed all the treatment modalities. Next slide. So these are our study outcomes. So as I was saying, feasibility were the primary outcome, safety and efficacy was primary, demoralization. And we also explore the impact of the treatment on all dimensions of quality of life, physical, psychological, social, and spiritual. And we're also interested in seeing the potential impact on caregivers' distress to have their loved ones participating in the trial. Next slide. So just to define very briefly demoralization, there has been a lot of work on this construct, which is the most commonly used to try to apprehend clinically the idea of existential distress. And the way it is understood is, so there are 5 factors that constitute the demoralization syndrome. When people's distress relates to the loss of meaning and purpose, there is the idea of dysphoria, distress, the idea of discouragement or disheartenment, the idea of helplessness and feeling trapped or stuck in one's predicament, and a sense of poor coping and sense of failure that is felt by patients. And all this is in reaction to external conditions, that are adverse, such as a serious illness. But people, the big difference with depression is there is no anhedonia. So there is still a capacity for pleasure in people in this condition. Next click. And so demoralization has been associated with, higher symptom burden, both physical and emotional. And also there are measures of associations that relate demoralization with increased death anxiety, increased perceived relatedness, so the sense of connectedness is influenced by demoralization and vice versa. And also attachment security impacts people's experience of demoralization. Next slide. So this is to highlight how we've been thinking about the 3 phases of psilocybin-assisted therapy: preparation, psilocybin session, and integration. So preparation is really about establishing therapeutic alliance with patients, getting to know us getting to know them, understanding really more in depth their experience of their terminal illness, and in particular demoralization. And of course, providing education about the psilocybin experience, including some navigation tools and grounding techniques to navigate through this, and also setting intentions for their experience. The psilocybin session, as I was saying, happens at the Care Dimensions Hospice House over a day, involves the non-ordinary state of consciousness, can be rewarding, can be challenging, and often includes spiritual experiences. And then integration is really facilitating the processing of patients' experience and working to fold insights into the narrative. And then this integration really is like how people individually process and integrate their experience and work with their social environment, and also how can we leverage the hospice care team to help and continue ongoing integration. Some of the key aspects of our approach include a non-directive approach, meaning that it's really very much patient-centered, and that we don't provide a very structured psychotherapy manual or teaching to people. And yet we use the concept of inner healing intelligence, acknowledging that, and that's the idea that in their experience with psilocybin, the participant's psyche is going to interact with the psilocybin in a way that will be self-directed by this inner healing intelligence towards healing. So it's the capacity of people to heal themselves that is facilitated by psilocybin. We have done a lot of work around music, used as a co-therapist, and also we acknowledge the spiritual dimension that the psilocybin experience may have, without remaining very agnostic about what that means. Next slide. Right, and I think that's one of my last slide, but so really to emphasize how, like, the interdisciplinary nature of our work, working at any stage of the screening, preparation, dosing, and integration with the hospice team, whether that is the physician, nurse, the music therapist, the social worker, and so on. Every time we had a patient being treated, their therapy dyad will meet regularly with the rest of the therapists to debrief around how their treatment was going, and will, like the other therapists may have input or advice or supervision to offer. Patients will be referred by the hospice team. We will discuss every patient with the hospice team of whether they would be good candidates, and on the logistics and the therapeutic aspects of their participations. Having a lot of clinical input to guide preparation from the hospice team, especially from the chaplains, from the music therapist. When we had patients who were followed by chaplains or music therapists or social worker, we'd have discussions with them ahead of time to get to know the patients and build our therapeutic approach based on the therapeutic alliance that was already existing with the team. And ongoing processing, shared integration visits, and coordination between all the stakeholders, really to try to build a form of psilocybin-assisted hospice care. Next slide. This is a photo of our altar here. So I will let Roxy follow with this slide. Yes, and tell us about our first clinical case.
Okay, great. Thanks, Yvonne. So I'm going to really try to keep this focused and brief for the sake of time so that we have enough time to hear about the second case and also have a discussion. But I'd like you to try to hold this case in mind as a contrast to what you're going to hear Aldo present next. So this is a lot of text, but I'm just going to try to distill down the essentials of this for you. So the patient I'm going to talk about, we'll call Sam. She's a young woman that Aldo and I treated together as the first patient we worked with in the hospice study about 1.5 years ago. She was a mother, and her hospice diagnosis was the chronic rejection of a lung transplant she received about 5 years prior for an idiopathic pulmonary fibrosis. She was slowly declining, very proactively enrolled herself in hospice in order to make sure her and her family's needs were met, and took a similar approach to working with her mental health, involved in psychotherapy, psychiatry, as well as couples therapy for her husband, and pursuing some individual therapy for her children. Sam was referred to us by her hospice team, who found her guarded and restricted in her way of communicating with them. And as a result, they found it difficult to kind of put their finger on the source or the nature of Sam's psychological, existential, and spiritual distress. So when Aldo and I met with Sam in preparation, what we learned is that her demoralization was centered around a feeling of being isolated and alone, and also the idea that she had been dealt a crappy hand. There was a lot of emphasis on the statistics and the odds of her illness in the first place being quite rare, followed by the fact that she was lucky enough to get a transplant, which then in turn ended up being rejected. So she felt very hard done by. Her personality style was, as I said before, very proactive and highly intellectual. She was able to use many, many words to describe, what her experience was, how it was affecting her family, what she thought about all of it. But again, we found, similar to her hospice team, a bit of a block in experiencing her internal emotional world. But she was pretty readily able to identify an intention for her experience with psilocybin, which was to connect with what she described as her heart center, or a place in herself where she felt she could really turn to when it was time to make difficult decisions. And she was also hoping to be more present with her loved ones. Sam's dosing day had a delayed start as she was having a little bit of high blood pressure, but her experience overall was pretty quiet. She really didn't interact with us very much during the dosing day and was really to herself and inside and in her process. So Aldo and I were surprised to learn at the end of the day, as Sam emerged and the effects of the drug wore off, that she actually had a very profound and powerful mystical experience. Her score on the mystical experience questionnaire was very high, as you can see here. And what she shared with us at the end of that day was that a big theme of her journey was one of unity. And I'm sharing here a quote from Sam about her experience that I think really gets at the heart of it. At one point, there was this stream, and everyone and everything in the universe was just kind of dipping in and out. And it's kind of like, you know what? It's okay. I worked out a lot of grief and distress, and I'm definitely more at peace with things. So the two things I want you to keep in mind when considering this aspect of Sam's experience is that spirituality and religion did not come up at all in preparation with her and were not a self-identified large part of her life. And the second thing is that this seemed to be generated entirely spontaneously and internally for Sam. There was not much conversation going on between her and us as the therapy dyad, and this is something that she came to on her own. And so the wonderful flowers of this seed came forth in the integration with Sam. And the way I would distill down her integration process is a movement from a place of isolation towards more active participation in her life. And this seemed to be mediated, at least in large part, by this experience of unity she had with the psilocybin. So through that sense of unity, it gave Sam a safe place from which to engage more actively with her grief, which she described as this locust that was shrouded in many layers of hard shell that she peeled away one by one and came to encounter what was at its core, which she described as the simple biological fact of her illness. It was stripped of any value, any judgment that it was bad, it was good, it was just a quirk of science, as she put. And as a result, she was able to, at least in part, successfully mourn. And following that, there was an increased presence to both herself and her emotions, which she described as, my emotions are no longer, shoved away in boxes in a storage closet. They're under my bed where I can choose to open them and engage with them at will. She was more present to her body in the more sort of detached and observant stance she took towards the increasingly severe coughing fits she developed. Her family, during the sleepover that her daughters had, she took the time to learn the names of all the kids that were over, and even the hospice team, with whom she started to show interest in the purses they were carrying around and shared her interest in purses, and everyone found her overall to be much more related. And in a brief epilogue, she died 6 months later and was at home until a few days before her death, where she did legacy work with a documentarian who's been filming our study. And then she made the decision to discontinue her immunosuppressant medications when the time was right. She waited for her kids to get home from school at the bus stop one more time, returned to the hospice house where she died with her family at her side. And I will now turn it over to Aldo to tell you about the second participant.
Thanks, Roxy. So Peter was an 81-year-old retired probation officer with a severe pulmonary fibrosis on home oxygen. So very similar kind of medical picture in some respects. In addition to his shortness of breath, rest, and progressive frailty, he was suffering from feelings of worthlessness, despair, being stuck, feelings of being a burden to his family. He would often say, "What's the point of this? I'm just waiting to die." Conversations often dwelled on his wife, who had died unexpectedly 5 years earlier, and his unresolved feelings of longing and incompleteness, and an anxious wish that they may be reunited after his death. His son and daughter-in-law, with whom he lived, both struggled to help him see the joy and purpose that they received in caring for him. They would share with the hospice team that their wish that he would just open up and share what's bothering him in his heart. Though raised Protestant, he married a devout Irish Catholic. He had not placed much emphasis over the years on religion or spiritual practices. When enrolled in hospice, he met with the teen chaplain and began praying with her weekly. His hospice team referred him for participation in a PATH trial to address spiritual and existential suffering underlying his poor quality. So, again, Roxy and I were the co-therapists for Peter here, and I think our experience in many ways was very different from our work with Sam. In preparation, I think the demoralization picture that sort of unfolded, though having sort of many of the same contours, was sort of tied to a different developmental stage in his life. He was, very much had, sort of complicated bereavement and unresolved grief related to the death of his wife 5 years earlier. And, the feelings of loneliness that kind of came with that sort of just augmented or amplified his feelings of being a burden as he declined functionally, became more frail, and required increasing care from his son and daughter-in-law with whom he lived. He was also a very different person. He was extremely concrete. Was not accustomed to talking about his feelings at all, and in many ways, had difficulty surfacing them in conversations, sort of about his, current condition and what his wishes were, for a sense of relief in the future. He had never engaged in psychotherapy in the past, nor had he any experience with psychedelics. So his intention, required a lot of coaching and sort of teasing out from the therapy team here. His sort of initial articulation was like, I just want to feel better, and trying to get him to tell us what better would look like. It could be, he was challenged to provide details, but he was able to say, ultimately that he wanted to live and not just wait to die. We worked very closely with his hospice team in order to be able to kind of really do a 360-degree assessment of Peter, given his sort of newness to this kind of like therapy model. We really had to recruit every resource we had at our disposal in order to best define what his needs may be. And in the 2 short preparation visits we had, develop tools that he could use to engage with the experience productively. So his hospice chaplain was an enormous resource for us in that effort. She'd been, really the person who had developed the most intimate relation with him from the team, and praying regularly with him, was able to kind of share with us both the language, and I think, some sense of the comfort level and intimacy of their prayer together. And we use that sort of as a stepping stone for building a grounding exercise with Peter. That was really a very, simple, kind of phrasing, prayer or mantra: Jesus, bring me your healing peace. And, I think with all of this legwork that we had put in, we knew that there were, many potential pitfalls that could arise during dosing. And some of them, I think we were able to prepare for. Many of them, I think, were unexpected. So he was very restless and had a difficulty settling in. And this was happening on a number of different levels. I think learning point for the team: tell patients not to drink 28 ounces of coffee before coming to their psilocybin dosing day. So he was having a lot of bladder issues, which many older men will have, and had to empty his bladder nearly a dozen times, during sort of the peak effect of his psilocybin. And during that time, we would accompany him to the restroom, and he was also having some visual issues, some difficulty kind of adapting to the eye shades, even though we had practiced this at home. He was someone who had, was having issues with vision as an 83-year-old, and working with the eye shades was difficult. He also, was hard of hearing and had trouble following conversations often. And, during sort of the peak of his dosing, he shouted out a couple of times, stop. And, we worked with him to try and understand what his experience was and sort of what he was, trying to kind of communicate and share. And, it seems like he was, struggling somewhat with some of the music, which, had voice, but not words that he could understand. He was frequently requesting as needed morphine, which was something that he was using at home to kind of regulate not just his shortness of breath, but I think also anxiety and sort of other feelings of distress. And throughout, he was just having trouble sharing his, what he was really experiencing then. And we deployed a range of interventions to support him through this experience. We did the grounding exercise and prayer numerous times together. We practiced therapeutic touch, holding his hand, just being present for him. We worked with the music. We had pre-selected, additional tracks and songs, that were sort of music that was familiar to him and kind of connected him with a sort of a sunnier time in his life. And we practiced movement, and eventually we even did try some medication and some morphine. When the drug effect began to clear and he was able to sort of articulate more sort of what he was experiencing, he really shared, was a very challenging experience that in many ways had sort of centered his experience of demoralization and amplified it considerably. And he shared a sort of a vision, a dysphoric vision of being sort of in the darkened recesses in the ceiling of a Gothic cathedral, and this sort of like feelings of an ominous presence, which I sort of read as kind of like an insecure attachment and something sort of a threat, something threatening kind of in the background. We, worked with him in, kind of counseling him using, I'd say, a variety of techniques, motivational interviewing and psychotherapeutic techniques in order to help him, kind of form and, get an early handle on this narrative that was already beginning to crystallize. But eventually, we decided on what was sort of a pre-discussed kind of backup plan if he were to have a difficult experience of a religious type, given his religious frame that he had kind of repeatedly returned to throughout the preparation. We knew that this was sort of the idiom and mode with which he was most comfortable relating his internal experience. And we had discussed both as a therapeutic team, but also with chaplaincy at the hospice house, bringing in spiritual care, as a means of helping him begin to process spiritually his religious experience. And so, Chaplain Dan, fortunately, was available to work with us. We brought in Peter's son and daughter-in-law who've been waiting in the lobby, and we did a very simple ritual that we often do at the hospice house for the dying, where a holy oil is sort of anointed on the forehead while both the person who is ill and in the bed is anointed by care team, loved ones, and hears their words of love and appreciation, but also sort of reciprocally anoints those present and is able to sort of share their thoughts, feelings, wisdom as well. And so I think this was a gesture that was both like concrete and meaningful, and it was a way of really bringing into the space sort of sharing of love and mutual appreciation. And through this process of sharing, he was able to kind of articulate a sense of purpose that was giving and receiving love, makes him of infinite value to God. On the way home, afterwards in the car with his son, he said something I thought was funny. He said, "Boy, I don't know what those people liked about those drugs back in the day, but I sure wouldn't do it again." So we saw him the next morning on our first integration visit, and we kind of immediately, I would say, like, sensed a change in his sort of like in his presence. He was able to relate to us, I would say, experiences, modest experiences of transcendence. So in his prayers that morning, he was able to really feel the receptive presence of God in a way that he hadn't previously. He also had sort of like a renewed and strengthened conviction that he would be, one day soon reunited with his wife for eternity. He, kind of shared with us his ambivalence about the psilocybin experience and his, unmet expectations. I think he had shared with us after the fact that he very much hoped that he would have visions of his wife and some experience with her, a taste of what was to come. And unfortunately, that's not what he received. But he was able to articulate that the demandingness of the experience in some ways would kind of, helped him form these new insights. So he shared sort of relatedness and reciprocity. He anointed us with a bottle of the holy oil that he kind of had returned home with from the hospice house He anointed his chaplain when she came to visit and pray with him. That night, his son had a 60th birthday party, and 60 family members came over to the house. And he gave each one of them a private audience and anointed each one individually. You know, they sat on his little, his rollating walker next to him, and he would, give them a little, pep talk and share what was in his, his love and what was in his heart. And he continued to do this, kind of practice alongside prayer for the remainder of his life. And I think from a palliative care standpoint, something that we really appreciated after the fact was how vulnerable he felt because of his sense of frailty. There was both the sort of the sensory impairment issues that we noticed during his dosing day. We sort of recognized how his apartment was dark, and some of his feelings of threat and vulnerability are recurring every day trying to navigate his home environment. Interestingly, his hearing, actually, his ability to understand others in speech was actually somewhat improved after that. This is just his report. And, he continued to have sensations of sort of fluctuation and discomfort in his body that we worked in sort of collaboration with his hospice team to manage pharmacology.
Wonderful. Thank you, Aldo. So I'm looking at the time, and I really want to make sure that we that we leave good time for discussion. So for the next maybe 10 minutes, Dan and I are going to talk a little bit more about Peter and his experience and Dan's experience in working with him during the dosing day. And before we launch into this, I want to frame this discussion and remind you, I think, of the really key thing to hold in mind here, which is consider Sam's experience, where the really, essential sort of core aspect of what seemed therapeutic for her was generated by an internally driven, spontaneous, mystical experience of unity. Contrast that with Peter's experience, in which the really core fundamental piece that he took and ran with was something that Dan actually said to him directly, which is that as long as you are able to give and receive love, you are of infinite worth in the eyes of God. So hold those two things in mind. And now I'll turn to Dan and ask you, Dan, what was your understanding of Peter's needs when you entered the room at the end of his dosing day?
I heard that Peter had some distress and that he was concerned about the feeling of worthlessness. When I go into a room, I'm always thinking that, from my point of view, everyone is eternal. So I have the sense that Peter is eternal. He has no beginning, no end, but he has an existence. My understanding of existence is a brief period of time that we are apart outside of the divine eternal. And the purpose of existence is to be able to experience love, to experience pain, and to learn how to suffer. My definition of suffering is to allow the falsity in me to be separated from the truth, which is me. So from my point of view, Peter was having a difficulty understanding that he was loved. So I just needed him to know that he was loved. And I shared with you before we get together, I prayed for Peter on my way down, and I just made certain that I made eye contact with him. And I said, you're loved by God, and I'm sure other people love you. And you people during the course of the day have been really attentive to him and loving toward him. And he had a good sense of humor. I look for two things for people to have: a sense of humor and to know that they're loved. As soon as I saw Peter had a sense of humor, I knew everything was going to be fine. So from my point of view, his needs were met simply by being able to know that he could be tapping into being loved. And the humor gives hope. The same thing with the other lady, with Sam. My understanding is that there's something in every human being that's not wounded. If I can find that thing within that person, I can help that person be in touch with that part of themselves, which is not wounded, then they can tap into the transcendental. They can tap into the love of God. Sam seems to have been able to do that. I'm aware of the time too.
Yeah. No, and that's wonderful. And what you say makes me think about, one of the core therapeutic principles that Yvan articulated, that we hold in the belief of the inner healing intelligence, right? Which makes me think about what you said in that part of a person that is not wounded, that maybe is able to generate that sort of creativity and life force. How do you understand the process of change that occurred in Peter over the course of the therapy?
I think he just found the people genuinely cared for him. He had a sense that he was loved. In the slides, it said to give and receive love. I would always point out, it's always receive and give love. We always receive love first, and that makes us aware. Peter had a sense of being worthless, and I think I even mentioned to Peter that you're unworthy of love. Nobody is worthy of love. It's just the fact that people love us that make us of infinite worth. None of us would say that I'm worthy of the love. I have a wife and she loves me, and every now and then I would say, I don't know why she would love me the way she does. We have a sense that we don't deserve to be loved, but the fact that people love us make us of infinite worth. Just tapping into that for Peter.
Yeah. And I think what you shared with me in our conversation before this presentation about the fact that you prayed and made yourself available to and connected to the Lord before you came into the room to work with Peter, and the arc that you conceptualized of being for, being with, and being as the other in your role as a chaplain made me think about how that's a really beautiful and poignant arc to think about our work as a therapist, right? If you're for doing the therapy for the patient, you want to tell them things, you want to tell them what to do to get better. If you're with them, you're really able to be next to them and near them in their experience, but to be as them, to really be able to step into and embody that other person's, subjectivity is something that's really hard to do. And I think the fact that you were able to sort of prime yourself before coming into the room may have been what made you, as you put it, able to really look Peter in the eyes and have this sort of connection with him that you did.
The major thing is to learn how to suffer. We all experience pain. We all experience love. Well, one of the things that we don't really learn, I think, is suffering. And I find that there is an inferior suffering, which is usually that which comes toward us. So when people hurt us, it hurts, and sometimes it's absolutely horrific. But that suffering is inferior. The more profound suffering and the more painful suffering is when we do harm to other people. When we come into touch with our own pain, when we come into touch with the reality of how we hurt other people, how we are totally unlike ourselves, because we're built in the image of God to love. When we don't love, that's when we're hurting other people. That's when we are not being our true selves. So I think as chaplains and as human beings, if we want to really be in touch with other people pretty quickly, we need to know how we have hurt other people. We need to come into contact with that suffering. This whole thing that we get hurt, that's bad, but that does not change our identity, our true selves, unless we resent it, unless we do something to hold on to it.
I'll now ask you, what role do you attribute to the psilocybin-induced state of consciousness in Peter's therapeutic process?
Psilocybin, I think, it gives you a little experience that can be good or bad, as you can see in the two examples. And it just taps into something that would give us the opportunity to be a bit outside of ourselves. But I think I mentioned that sometimes if we look into the eyes of someone who loves us, that can be a psilocybin experience. That can be equivalent to a psilocybin experience. If I can see that in somebody's eye that I am cherished, that gives me the opportunity to know I'm loved. If I can have some type of experience, just simple joy watching the sunset, like Tranquil with logotherapy, that's a type of experience where I'm outside of myself. I'm transcending, but also I'm getting in touch with my inner divinity. I'm getting in touch with my eternity, and that helps. Psilocybin is one of many ways to experience it. And from my understanding, prayer and meditation would be simply the ordinary way to maintain the awareness of being of infinite value, of being cherished and being precious in the eyes of God and others.
Yeah. We could go, I think, many directions with that thread, but let's end with the last question, which is what role do you attribute to the anointing ritual in his therapeutic process?
Anointing is something that signifies love. Anointing comes from the olive oil. You have to beat the tree to get the olives. You have to crush the olives to get the oil. There's pain involved. There's also joy. So with the oil, it's kind of a symbolic thing of pain and joy mixed together. You're celebrating love and celebrating the pain that he experienced. Peter was able to take that, suffer with it. He took the love that he experienced, the pain that he experienced, the suffering, he integrated the two. The anointing became a symbolic activity of that. And I was so delighted that he did so many other people.
Yeah.
It's almost 6:40, time for questions.
Yes, that's right. Well, that's a great place for us to end. And I think that we're going to turn it back over for a little bit of follow-up about Peter before we launch into the discussion.
Yeah, just to kind of bookend, his care. So Peter had a very quick decline after his enrollment in his completion of the PATH study. He unfortunately was found at home having fallen and broken his hip. His hospice chaplain found him and contacted the EMS. He went to the hospital, had his hip repaired, kind of had a rough stint at a skilled nursing facility, kind of during COVID times, and was unable to really kind of engage fully in rehabilitation, and ultimately returned home, where he re-enrolled in hospice and died about 10 days later. Throughout this time, he continued to sort of practice anointing his loved ones, and maintained sense of sort of spiritual resiliency that we had seen in the days immediately following his dosing session. And these are just a kind of a few excerpts from the qualitative interviews with his loved ones, but I'll just kind of focus in on what I think is most salient. Made us close in tough moments. He's not one to openly share feelings on a regular basis. This really made him feel more comfortable at expressing things that we never knew about him. We felt closer to him. He felt closer to us.
So we had another quote from Pankey, but I'm going to skip this maybe to the next. You guys can refer to this in the recording. And we really, we want to save time for questions. I think some of the clinical case, speak for themselves about some of the questions that all this raised for us. The importance of multidisciplinary team and this collaboration with chaplains, this idea that with this challenging experience of Peter and like from a spiritual dimension and Dan's intervention, it's in medical term, we had to report this as an adverse event, during this dosing experience. And in some ways, here the rescue intervention was not a medication to calm his anxiety, but has been like bringing the chaplains in. So what does that mean in terms of how to implement this this treatment modality, in patients who might have this kind of adverse experiences? And we also identify attention with the ethical dimensions, like between being able to offer religious interventions, in patients who are in a suggestible and vulnerable state, and like really being mindful of respecting people's autonomy and sense of agency, and like what belongs to us, what belongs to people. So really, how do we are mindful about that? And at the same time, seeing that religious offerings might bring comfort to patients who experience, like we showed with Peter, and how relieving Dan's intervention has been for him. then how also to ensure cultural appropriateness of these spiritual care interventions and of our spiritual care or therapeutic intervention in general. This paradigm of beginner's mind and inner directed approach, inner healing intelligence, and at the same time, how to think about that in knowing that people may have real ontological shock in their experience, and how do therapy teams like us work to increase awareness of their own beliefs and the role that these beliefs play in the therapeutic container. Right, and what are the implications for informed consent of all of these considerations? So thank you so much for your attention, and we're more than happy to respond to a few questions.
Wonderful. Yes, there are a number of questions, but first, just thank you all so much for the presentation and for the work that you're doing, which feels so promising and also just so heartfelt and important in these patients' lives. I want to start with a question of my own that's also pulling from a number of questions here in regards to the use of the mystical experience questionnaire, or the MEQ. Both Paul and I have actually published our skepticism of the MEQ and sort of concerns around the way in which Walter Stace drew from religious traditions and sort of molded different traditions to sort of suit his understanding of mysticism, and also concerns about the way that it can potentially inadvertently shape a patient's experience depending on how it's deployed. And so there's sort of three questions here, which are pulled from audience questions of my own around it, around the MEQ. One is, when specifically was the MEQ deployed? And do you see any possibility that going through the MEQ questions was actually shaping the patient's experience or their understanding of the experience in some way? The second question is just around the choice of the MEQ and if other questionnaires, psychometric questionnaires, were looked at, and what went into the decision for the MEQ. And then finally, were there any patients, I don't know if Peter maybe is an example, or were there any patients who, in going through the MEQ, were just like, this is not my ontology, this is not how I see the world, or otherwise sort of found it uncomfortable to be thinking about their experience in those terms? And
yeah, great questions.
Anybody can answer. Sorry.
Maybe I'll give it to start just on a research perspective, and then see if my colleagues have other ideas. But so first of all, we deploy the MEQ questionnaires along with the CEQ, which is the Challenging Experience Questionnaire. And those two, like the goal is to capture not only like ineffable, mystical, positive feelings about mystical experience, but also experience that might be more challenging, and that, so the CEQ refers more to distress, grief, sense of aloneness and isolation, etc. And so I think it's important to explore both potential dimensions of their experience. And so the timing of when we have people complete these questionnaires is either at the very end of the dosing day, so around 4 or 5 p.m. when they're returned to baseline consciousness, and if they feel able to complete this before returning home, or the next day, so after this. And yes, I think that's a very valid point. I think having them contemplating those questions may frame how they view their experience in a certain way, definitely. Is that good? Is that bad? I don't know, but I think that's very much likely that it does to some extent, and that it's good to be aware of that, and just the last piece that I'll respond before letting my colleagues answer is, yes, for some it's not so much that for some participants, it's not so much that they feel uncomfortable with the ways those questions are framed. It's more that they don't recognize their experience in those domains, and their experience was something else, which is why we are interviewing people to make sure that we have a direct way to understand their experience in their own words, And we use also other type of questionnaires, like we explore, like we have a spiritual well-being questionnaire, we have like a demoralization scale I mentioned, we have a quality of life questionnaire, social isolation questionnaire. So we're trying to see what makes the most sense in capturing, and people may have so unique experiences that it's hard to use to capture that in one questionnaire, definitely. Yeah. Roxy, Aldo, any other thoughts?
I don't know that I have anything to
I
add.
would just add that in terms of like timing and flow during the dosing day, what we experienced in both of these cases is that as they emerged from the non-ordinary state of consciousness, they were both participants were very eager to engage with us in a in dialogue in a therapeutic framework. And I think in many ways, quite spontaneously, what happened during sort of this period of observation while we were with the patients was an early integration session. And the questionnaires were really filled out just prior to discharge, to a discharge home. And so a lot of the sort of initial formulation occurred before any priming from the questionnaire.
But maybe I'll just quickly, I do have some things I just want to underline, is that this question makes me think about maybe how it's not entirely accurate to frame Sam's experience as like totally spontaneous and inner-directed. If in short order after she had the experience, we did provide her with this questionnaire that one could argue is, to your point, like it is suggestive, it is directive. And I think it just is important to consider like what that means.
Yeah, that was how I was thinking about it. I mean, Walter Stace, who sort of provided the philosophical background for the MEQ, was all about unity. It was like that was the hallmark of the experience. And so it's interesting that that language was picked up by whether it was her experience or not. I mean, I think it's just something to consider. And yeah, it sounds like in so many ways the study design is trying to account for these things. So it's great to hear. Thank you all for the answers. Paul, I think you had the next question.
Yeah, I'm super curious about if you recall, what Peter's MEQ score was.
Did we pull that up? That's a great question.
It's not in our slides.
Yeah. I mean, we can get back to you, and this will definitely be in the report. Like I think we'll write about those clinical cases. I don't think we've. That's a. We should have. Like added this score, to the slide. But I'm not sure if
No problem at all. But I would be super curious to compare, because at least from my own understanding of mystical experience, I would consider the whole sort of the day, with the anointing and all the rest, as having very sort of mystical components. And I would be curious how that sort of squares up against his score, which leads to my question of, do you all have an operative definition for mystical experience or mysticism? And in what ways has it been shaped by using this questionnaire, or does your own understanding of mysticism, is it sort of a separate question? The MEQ's utility is sort of from its predictability for positive treatment outcomes. And so I'm wondering if your personal understandings of mysticism is something similar or something otherwise.
Could I interrupt on that one?
Please do, Dan. Would love to hear from you.
In the Jerusalem Bible, the hardback edition, in Ephesians chapter 3, there's a footnote. It's either K or L, depending on which edition you get. It says, knowledge of this type cannot, really dealing with the love of God, knowledge of this type cannot be grasped in a philosophical sense, but rather it is more like knowing that one is loved rather than knowing the one who loves. I find that to be one of the hallmarks of true mysticism, to know that one is loved, even if you don't know who the heck is loving you.
Sure. It's coming from somewhere.
Yeah, Peter had that sense, and Sam was able to have that sense of being in oneness. Yeah, for anybody who has the Jerusalem Bible, the hardback edition, the footnotes aren't in the softback edition.
Okay, noted. I will definitely be digging in there. And what about the rest of you? Any sort of definition of mysticism coming into this?
Yeah, I mean, I think we all come sort of primed with our own sort of experiences and practice. I think my interest in psychedelics and interest in medicine was sparked during travels in Mexico, in which I had the opportunity to experience these practices firsthand. And that mystical experience, I think, in many ways kind of informs my expectations or my hopes for others. And as I've gone through the process of participating in the clinical trial, I've realized the diversity of people's needs and how that experience is really just my own experience. And there's been a process of kind of like divesting from our own individual expectations. I think we've worked collectively as a team to build through this deliberative process and group supervision.
Maybe I'll just add that even though this presentation, we're talking a lot about mysticism and mystical experiences, and it may give the impression that that's a central piece of how we frame the therapy for people, and that's actually not true. Even though we prepare patients that there might be a spiritual dimension to their experience, and that people have described experience that we call mystical or others kind of challenging experience, but with spiritual dimension, we don't have a strong suggestion that this should be the kind of experience that people experience to benefit from the intervention, and we approach this in a much more interrogative way, and really we are in the process of investigating how these interventions work, and if they work, and if they're safe, and we don't really don't know, so even though we come with all those notions, around mystical experiences and psychological processing, emotional breakthrough, etc. Like, we're still very much trying to learn how this works for people. So we are also cautious about not creating too much expectations around all that, especially during preparation.
I know we're getting close to time, so I think we maybe just have time for one more question. I'm again going to sort of combine a few questions from audience members to try and hit a few people's questions, but this has to do with music and the role of music in the music therapy. Could you say a little bit more about how the music was chosen? Was the therapist coming in with a particular understanding of what the music would be doing, or a particular modality? Any other information that might be relevant about the music and what role that was playing in treatment?
Yeah, I feel we need another hour for that one. We've been very fortunate to collaborate with a music therapist, PhD music therapist, Lisa Sommer, over the past 3 years, and really think carefully about how we would approach music in this trial. Lisa was Helen Bonny's mentee when Helen was alive. And so she's been a student of Helen Bonny, who was one of the pioneers of LSD research at the Spring Grove Hospital, and who designed the music programs at the Spring Grove Hospital in the early LSD research with Stan Grof and Walter Pahnke and Bill Richards. So Lisa, and then Helen Bonny developed GIM, guided imagery and music, in an attempt to replicate really the work with LSD, assisted therapy and music, but without the psychedelic agent. And so Lisa brought her expertise in GIM, music therapy, and we did a lot of work around music to create a music program that reflected both the intention of this trial, like addressing demoralization in patients with terminal illness, the kind of, music that we felt would be supportive of people's experience through the arc of a psilocybin effect, over the day. We paid a lot of attention about people's pre-existing relationship with music, during preparation as well, and see if we can bring some of that into, the use of music during their experience. Anyway, so we've had a lot of considerations where, so we used a purposeful music program across our patients but we're also all the therapists, all of us were very familiar with this music program because we all co-created it in some ways. And so we were able also to play with it, to some extent during the dosing in a way that was more personalized. Right. Any other stuff that my colleagues want to add?
Maybe just that, people reacted to it differently. Like you saw with the patient Peter, it was really challenging for him. And, the program, I think the music program was obviously created with a lot of thought and care, but it's interesting to think about, some music is such a subjective experience. So it's interesting to think about, how does it interface with different people, their tastes, their feelings, what it evokes. And, thinking about our participant, Peter, he was an older gentleman with probably limited exposure to certain types of music and also hard of hearing. And so hearing something that may have been challenging or confusing for him to understand, what does that mean? So just that, it's complicated.
I saw questions about nature as well. That's such a great question, can we just open the door and bring people into nature for, to bring something else in their experience? And I think we have learned so much about music, nature, eye shades, and like all those elements that are classically part of like psychedelic experiences in a clinical setting. Like, what does that really mean when for people? And like, is that required to keep the eye shades and the music throughout the experience? Can we just open the door of the patio? There is a beautiful nature in those rooms, like where we have people for the dosing. This opened on a patio with a landscape garden, and there is a pond in the Lincoln Reservoir in the back. And many of our patients have asked us, "Hey, can I just go walk and connect with nature?" And because it's a clinical trial, and because we are concerned by safety, and we haven't allowed them to go beyond the patio. So for many people, it was just sitting on the patio and then just taking in the sun and the beautiful nature. Others wanted to just lie down in the grass. And so how do you deal with that on the spot in the context of a clinical trial when there are other patients and families around, and anyway, so all this is great learning experience and clearly shape people's experience as well. So yeah, work in progress.
Well, thank you all so much for sharing this this research in progress. It's always a challenge, I think, sometimes to share a project that you're in the midst of. And so I appreciate your vulnerability in bringing us into this, a window into this project. With that, I will let you all know a little bit about what is to come in Psychedelics in the Future of Religion and other things, other programming that the CSWR has going on. Here up on the screen, we have the Curious Case of Integration, our next PFR event with a number of integrators from various places and contexts. This will be on March 20th at 5:30, and you can register online on the CSWR events page. And then our next PFR event will be on a book that came out last year called Ayahuasca as Liquid Divinity. We'll be speaking with the author, Andre van der Broek. And then we'll have a new series, Psychedelics and Ethics, that will be launching in person on Tuesday, the 16th of April at 5:30. And registration will also be on the CSWR events page. And with that, I will conclude this event. Thank you all again to our presenters for sharing this project and these beautiful cases. This is such personal work to meet people in the end of life in this way. And thank you also to our audience for your careful attention and your thoughtful questions. And with that, good night and see you soon.
Thanks for having us.
Thanks for having us.
Sponsor, Center for the Study of World Relations.
Copyright 2024, the President and Fellows of Harvard College.